See everyone. We've got a smaller group today, so feel free to chime in. Let me share my screen here. Okay. My name is Shamsher Samra. I'm emergency medicine faculty at Harvard UCLA. I'm going to be presenting today with Dr. Shia, who is emergency medicine doc up in Contra Costa County and director or the medical director of the health plan, and Dr. Schneeberg, who couldn't join us today but helped with the presentation, is the assistant program director at LAC USC. Today, what we're going to be talking about is treating violence, body and soul, and hopefully we'll explain a little bit more about the title. But one of the kind of motivations for doing this presentation, and we don't have any disclosures, is there's been a lot of conversations around violence in recent months or within the last year. Not to say this is kind of a new phenomenon, but what we're hoping to do is we're hoping to contextualize a bit about both kind of some of the social and structural determinants of violence in the United States, but also how our healthcare system articulates with those processes historically, the limitations of how we've engaged with trauma and violence in the past, but opportunities for how we can provide trauma care in a more holistic manner, and potentially provide some counter narrative to some of the things that are being suggested as responses to the increased violence that we're seeing these days, unfortunately. So folks have probably seen a lot of headlines that express the sentiment that's conveyed in these charts, but essentially over the course of the last year, in the setting of the pandemic, we've seen homicides and kind of interpersonal violence increase across the United States. And we've seen this in Los Angeles, where I work, up in the Bay Area, but then also kind of around the country. And what's kind of come alongside this kind of epidemiologic representation of this problem is explanatory models, like what's going on here, why are we seeing this uptick in violence all of a sudden? And people have proposed all sorts of theories, ranging from it's related to isolation, decompensation of mental health issues, a surge of the sale of guns early on in the pandemic, to kind of the social and economic instability that followed, especially kind of with or in the midst of kind of the economic crisis that was a sequelae of the pandemic. And we're not here today to necessarily give you, what the one true answer is, because I don't think anyone genuinely knows, but to potentially provide some structural and historical framing to what's happening now. And the thing that's kind of followed from these different hypotheses of what's driving the increases in violence is, what are the solutions? And it's a very particularly interesting time right now. Prior to the pandemic, there was an uptick in physicians advocating for gun control, are becoming increasingly engaged in gun violence advocacy. We also had this uptick in violence occurring around the time that we've had a lot of conversations in this country around racial justice and police violence. So at the same time, we're having conversations about defunding the police, we're having increases in violence, and the solutions moving forward are, do we just need more police back again? Is this a separate phenomenon? Do we need more mental health workers, or is it something entirely different? So with that being said, I kind of want to go to this chart here and just kind of put it into context. We're over on obviously 2021, and there's definitely a dramatic increase in the rate of homicides in the United States. So you can see, if we put it in a historical context, it's at or below the levels that we saw for almost 3 decades here in the United States. So if we rewind a little bit to see what was going on back at that time period, maybe it'll help us understand what's happening in the current period of instability. And there's obviously no way to provide a comprehensive overview of this, and people have dedicated their careers to understanding this, but it's just to maybe raise some of the structural shifts and trends that happened over those 3 decades when we did see higher rates of homicides and violence. And a couple of the things that I wanted to highlight is, one, the graph on the right. This just shows how inequality just exploded in the United States, kind of in the late 70s going into the 2000s. The chart's not labeled, but the top line there is the top 1% of folks, and then we have income quintiles. So economic inequality just blew up. And at the same time, for the majority of folks, the real wages and kind of standard of life that they could sustain actually decreased over this period of time. We had processes going on at the governmental level of austerity and neoliberalism, which essentially meant that we were going to withdraw or reduce kind of social spending and investments in social infrastructure. At the same time, we had, in this kind of lack of social services, increasing economic instability, we had, kind of the war on drugs also emerged. So suddenly, as people are becoming, less economically stable, have less social support services and benefits, suddenly we're starting to penalize poverty, addiction, and all of the other things that folks are probably familiar with. So together, folks like Ruthie Gilmore, who's kind of an abolitionist scholar, talk about these trends as organized abandonment and organized violence. Organized abandonment refers to collectively society decided that it was going to abandon large portions of our society, geographic areas within our communities. And this included not just housing and GR benefits and those types of things. It also meant that there was going to be closures of hospitals, primary and preventative services, mental health resources. You can see the chart at the bottom referring to deinstitutionalization. So mental health hospitals closed, and increasingly folks with mental illness found themselves in prisons and jails. So this is kind of some of the structural shifts that are happening in this country as we saw an uptick in violence. And this organized violence, or in other words, structural violence, is oftentimes overlooked when we're thinking about kind of the root causes or the social determinants of violence. Oftentimes, it becomes a very easy kind of slogan like, we need to stop violence. Why is violence occurring? We just need to kind of stamp it out. But if you look at it from a structural historical lens, you recognize that basically we've created situations or structures or environmental conditions that create moral economies of violence. And what this kind of sociologic term sometimes refers to is that we've thrown so many people out of formal economies, meaning formal, regular, full-time working jobs, that large swaths of society are dependent on informal economies for sustenance to make a daily wage or living. And these informal economies are not oftentimes regulated. They place individuals at increased risk for violence. And in these scenarios, violence becomes a reality of everyday life. And it's only if we can fully grasp all of the dimensions that kind of contribute to violence that we can begin to start addressing it. But what actually happened in the United States, and again, there's folks on this call that have probably a lot more expertise in this, but is around the same time, the 70s going into the 80s and the 90s, we have the advent of our profession, emergency medicine, but also the advent of the contemporary systems of trauma. The first report, or this kind of report on optimal care of the injured patient from the American College of Surgeons Committee on Trauma, came out around 1979, around the time that emergency medicine became a board, certified specialty. And a lot of the messages that came out of this report were drawn from experiences in war, Korean War, Vietnam War in particular. And on face value, the lessons that came from this manual and from these interventions, in other countries, did improve the outcomes for folks who are traumatically injured. But if you just think about it, in some ways, what we're doing is we're implanting a model of trauma care that comes from extracting people from foreign settings that are in the midst of war and applying it to our domestic situation, where in theory, we're supposed to be ingrained and, collaborating with our communities. So,
Dr. Samra?
Yes.
There's a question in the chat real quick.
Sure, yeah.
It was regarding informal economy, which is a term that myself and also Dr. Ding was not familiar with. Could you please give a quick example?
Sure, yeah. So informal economies are basically, things that people might be doing, not to say kind of like under the table, but refers to all sorts of things that you're not necessarily reporting kind of taxes on. It's not something that you're getting a W-2 for, whether it's, repairing your neighbor's kind of car on the side, whether it's kind of doing cleaning, whether it's selling drugs potentially, whether it's doing odds and ends for other folks to make a living. And it's basically all the jobs that aren't necessarily accounted for in a lot of our job metrics. And sometimes because they're informal, these are kind of economies that aren't necessarily protected by laws and regulations. So folks that are kind of participating in these economies are exposed to violence at higher rates. For instance, if you're someone who's resorting to selling drugs to make your living and someone comes and steals something from you, it's not that you can go to law enforcement or you can report it to some bureaucratic office, right? So suddenly violence becomes part of that moral economy is what it's alluding to. So just kind of going back to how we kind of set up our trauma systems, it basically was not in isolation. It wasn't just that this was the best model we had. It was ingrained with some of the institutional racism that existed within medicine. You can see this headline from the LA Times, which refers to this kind of racist idea that there's these other type of people who live in the inner cities of our cities, and they're basically violent people, and they're preying on people elsewhere in the suburbs that are more affluent and more white. And this contributed to this notion that we're just going to provide these communities just enough care. Where if someone's violently injured, we're going to send an ambulance, retrieve them, bring them to our state-of-the-art trauma center, provide the best emergency and trauma care, and then we're going to discharge them back to that other place. And this kind of framework of thinking is kind of reinforced with this photo on the right is a picture of the Black Panthers ambulance. So the Black Panthers set up their own autonomous ambulance service for a couple of reasons. One was ambulances were significantly delayed in coming to communities of color, poor communities, leading to worse outcomes. And then also the fact that ambulance services were often closely intertwined with a response from law enforcement. So again, kind of almost reflecting this colonial relationship between the healthcare system and poor communities of color that existed. So this institutional racism played into, again, this model of trauma care, which is great in the sense that once a person got there, we're going to do all the things that we need to do to get them the best outcomes, but we're completely separated from those moral economies of violence that I mentioned earlier, those structural conditions that I mentioned earlier, and we're not engaging with those factors. So if we, kind of come to our contemporary moment, I think if we think about that history and the way some of these systems were set up, it helps us understand, some of the outcomes that we see when it comes to trauma. And folks are probably familiar with, some of these numbers here. This refers to, says recidivism, but it should probably say re-injury instead. Basically, that high number of folks, 5 to 40% in some studies, once they come into a trauma center, urban trauma center with a violent injury, they're going to be re-injured within 5 years. And it just gets to the fact that even though we're addressing the injury, we're not addressing a lot of the social and structural determinants of injury. And then in addition to the things that predispose to violence and injury, there's also the things that follow from traumatic injury. We know from some of the literature that 40 to 50% of folks who are affected by traumatic violence will suffer from PTSD, but it's not routinely incorporated into our trauma protocols to get folks connected to mental health services, which we know can be even more challenging for folks to reach compared to medical care or emergency care for sure. So this is kind of where we're at now, and this is kind of how we got here. And before we segue into the next section, Dennis, I think maybe it'd be useful to maybe just pull the audience a little bit to get a gauge of where people are coming from. Do folks have some familiarity with kind of hospital-based violence intervention programs, or have they participated in those? And obviously no worries if it's, okay, good, yeah, yes. Cool. So we have a couple yeses. Great, so we're just gonna try to get a sense of where the audience is coming from. Dami is familiar. All right, so I don't know if you want to take over for the next slide here. I think Dennis may be having audio issues, but so I'll go ahead and continue here for a bit. So this just basically gets to all the levels that we talked about earlier, in terms of the vulnerabilities that potentially predispose to violence. And this alludes to some of the same statistics that we've seen in our LA population. So the comorbidities, both medical, but then also housing insecurity, mental health issues, issues with community safety and community efficacy, which also are another thing, factor that aren't addressed in our routine trauma care. And this, refers to, sometimes we think about what are the root causes of violence, but then this again gets to some of the sequelae that follow from violent injury that we oftentimes don't even track, because once a person is cleared from the trauma service, they're discharged and we don't routinely have follow-up. So mental health, PTSD, as I mentioned, exacerbation of use of drugs, disability that may limit ability to acquire a job or sustainable income, re-injury, which I mentioned, loss of employment, and then kind of deterioration of community and social ties, particularly when we're talking about retaliation and fear that may exist after this type of injury. Maybe let's stop for just 1 second as Dennis gets back on. Did people have any kind of questions about that portion or any thoughts? All right. So basically, we're going to move on a little bit, and this is getting back to, this shows that healthcare expenditure, where the United States stacks up compared to other countries, and reinforcing that point again, that we're particularly good in spending a lot of money in our health infrastructure, but not necessarily so well equipped to set up systems that support communities and fund communities. And it's important to keep this in mind with a couple of things that we're going to talk about a little bit later. Some of the interventions that we think will be very powerful in terms of moving the needle or shifting the agenda for violence intervention work, including Medicaid funding for violence intervention programs, are still things that are going to flow through the health system. So just to be cognizant of the baseline kind of inequities and imbalances that exist. Dennis, are you back on? As Dennis gets back on. So this chart just kind of highlights the similar thing, that again, there's a huge imbalance in the United States right there in the middle, where we spend a lot on healthcare, but not so much on social care. And if we recognize that the primary drivers of violence and re-injury are in the social domain, what does it look like if we actually want to undo the history that we just talked about and invest in communities? So how do we fix this? And this is kind of the bulk of the remainder of our presentation. So,
you guys hear me?
Yep, hear you, Dennis.
Perfect. Sorry about that. I was having some audio issues.
No, you're good. I kind of stole a couple of your slides there, so you can
totally fine.
You can redo them if you.
All good. So we can just go. I think if you run through those, I can just pick off where you left off, Shamsher.
I think we were right about here.
Okay, perfect. So can you guys see my screen?
Oh, let me stop sharing.
Okay. Can you guys see my screen now?
Yes.
Perfect. So as Shamsher laid out, right, in terms of our trauma system, in terms of, sort of thinking about this, I think Shamsher's laid out the complex history and the framework. And this is a slide that, if you've seen me present, you've probably seen it before. It's really saying, we need to think outside the box and address these different issues, not just the clinical care, because all these social and structural issues that Shamsher talked about are sort of the reasons why some of our patients are either victims of trauma or sort of have bad outcomes after being a victim of trauma. And, sort of in terms of our patient population, this is sort of in LA County, our baseline patient population, and all of these factors, unfortunately, are enriched in our trauma patients. But it shows that, obviously, there are a lot of issues in terms of these social determinants, and by ignoring these issues in the trauma setting, we're doing our patients a disservice and not looking at the whole picture. And I think Shamsher covered this already, but in terms of lots of different other things we should be thinking about in terms of caring for our patients, not just their physical injury. Obviously, mental injury is huge, but also a lot of these things are either contributing factors or more often the result of trauma. And I think to really take care of our patients correctly, it's really thinking about how do we address all these other issues as well. And in terms of spending, in terms of spending in the U.S., people are always like, well, we're talking about all this stuff, but all this stuff is expensive. How do we address it, right? I think, if we look at our healthcare system, we spend a lot more money per capita than anybody else. So it's not like we're not spending money. We're just spending it potentially in the wrong places on sort of clinical services as opposed to addressing social determinants and reinvesting in our community. So I think that's sort of really where the rest of the talk goes in terms of treating trauma. It's, once again, we're not here to talk to you about the thing you're unfortunately all too familiar with and that golden hour of trauma. It's really talking about what else we should be doing that should be the standard of care, but that we haven't necessarily started doing. Some places have these programs, a lot don't. So I think, probably for the group, hospital-based violence intervention, something that some of you are familiar with. This is sort of, I think, the canonical intervention, if there is one, around trauma in terms of hiring individuals with lived experience who've been victims, often, unfortunately, either they themselves or their families, and bring them not just sort of into an individual's life way later, but really starting at the bedside when they come into this trauma bay, after they've been stabilized, really not just saying, okay, we're going to discharge you, but having someone come in and talk to them, using that event as potentially a teachable moment or at least a thought-provoking moment. And, part of the work is to prevent retaliation, but also really to sort of provide relationship building and support, because as we saw a couple slides ago, once you've been a victim, there is a lot of different things that you are coping with from a mental health, from a social perspective, and a community perspective, much more beyond your physical injury. And I'm sure if you have any additional thoughts on this piece.
I think it's just to kind of raise the point that, we recognize that these are effective evidence-based interventions, but they're still, as we've experienced, they're grant funded and they're kind of dependent institution to institution. So what does it take to make this standard of care? Because if there was any other kind of medical conditions where we knew that there was a 40-50% chance of reoccurrence within 4 or 5 years, or 4 to 5 years, and we didn't do anything about it in terms of follow-up, it would be kind of considered unjust. So we have to think about the kind of racial equity dynamics of why it is that particular populations that are particularly affected by violence don't have these evidence-based interventions formalized into routine trauma care, and how do we get there?
Right. And then sort of, following up on that, right, sort of really the theme of, yes, you want to start engagement, but, as ED docs, there's the term treat and treat, right? And I think this is really looking at that, sort of getting to that point that Shamsher talked about. If you have a 40 to 50% chance of re-injury within 5 years, we have to look beyond the hospital and the trauma bay and really sort of say, even if, we are not necessarily as a physician going into the community, but, how do we link with primary care? How do we link with all those social supports, families, friends? Those are generally protective. How do we work with community-based organizations and institutions to really address these and provide that net to address all those issues beyond that physical injury that sort of predisposed that individual to violence in the first place? And with that, sort of, how do we continue that care? And for us, sort of really to take ownership and say, we as people who see the effects of this feel this is important. This is where resources need to go. We don't need an 8th trauma bay, right? We don't want to build a 9th trauma bay or another OR because we have more gunshots coming in. We need to sort of reinvest, figure out the root cause, and reinvest in our community. And then in terms of mental health services, I think this is sort of, on the spectrum of what people are familiar with. I think everybody's familiar with physical health interventions, and many of you are probably familiar with hospital-based violence intervention programs. But I don't think, as a whole, I think all of us from working in the emergency department realize that our system of care for individuals with mental health illness or mental health concerns or conditions is horrible, right? And this sort of is not, if you look at someone on a hold, it's a pain point across the country, right? There's not enough outpatient treatment, not enough diversion services. But I think this area is especially acute when it comes to trauma. Basically, I think by definition, if you've been experienced trauma, you're going to end up with PTSD. But there's a lot of stigma around it, and especially in the communities where a lot of our patients come from, and that stigma is huge and a huge barrier to engagement. And I think, one thing we found is our intervention workers who have lived experience are able to sort of share their experience, provide a referral from a place of trust, and really help overcome that barrier to engagement. And, at Harbor and in different places across California and the U.S., there's this sort of second model, the Trauma Recovery Center model, which is a trauma-informed approach to helping and working with individuals who are victims of violence and treating them and providing access to mental health services to sort of strengthen and build upon the relationship from care management. And, for us, similar to what Shamsher said earlier, that the hospital-based violence intervention program should probably be the standard of care and really be at every institution that treats individuals who are victims of trauma. We, from our experience, feel very strongly that not having a mental health arm, something like a trauma recovery center, is doing a disservice, and this should also be part of the standard of care. And Shamsher, I know you also have some thoughts on this.
No, I think you covered it pretty well, Dennis. And I think, just recognizing, the value of community and making those connections between mental health services and populations that may be affected by violence and trauma, particularly when there's concerns or potentially mistrust of the healthcare institutions, stigmatization of mental health services, the value of bringing community into the fold, whether it's kind of peer navigators or community-based organizations, and bridging that divide is incredibly important.
And then I think, in addition to sort of providing care management, longitudinal accompaniment, and addressing mental health needs, this is sort of something that comes up quite a bit, right? We know sort of there are existing resources in the community in terms of programs individuals might be eligible for, community-based organizations providing services, and often that accompaniment gets over that advocacy gap in terms of helping connect people to those resources for whatever reason, whether it's stigma, whether it's lack of knowledge, whether it's lack of transportation, right, whether it's literacy, and help people access the existing resources. But there's also a resource gap in terms of things such as housing and sort of some of those structural things in the communities that are lacking. And we'll talk a little bit more later about sort of how to overcome the resource gap. But, there's a lot of partnerships that can be formed, and Shamsher can share some of his experiences and some of his thoughts as to sort of the different ways to engage with a broad groups in the community that are doing good work and sort of bring them into the space to create resources for individuals who are victims of trauma. Shamsher, do you want to talk a little bit about sort of the housing work you've been thinking about and other things?
Yeah, thanks, Dennis. And I think one of the particular challenges is that folks may have different experiences, but it feels as though there's a lot of movement that's happening related to addiction and mental health. Obviously, there's still huge resource gaps in terms of the programs that we need and the supported services that we need. But recognizing the experience of trauma as someone who's at risk of trauma being a vulnerability that also warrants expenditures and dedicated resources, or kind of a preferential treatment for lack of a better term, is something that we've been trying to push on here, at least or locally in LA County. And just one kind of example of that effort has been conversations around diversion, so diversion from the jail system, where there's a big push to divert folks who have mental illness from the jail system and into community-based systems of care, investing in those systems. Same thing for folks affected by addiction, but folks who have been participated in violence or been affected by violence, and oftentimes it can be a part of the same continuum, are oftentimes ostracized and neglected from these conversations, and therefore neglected from the conversations of investing in community and supportive housing, housing for help type services. So part of our work, in the emergency medicine arena and in the world of social emergency medicine, has been talking to folks to be like, look, violence should also be framed within a public health type of frame, and also requires similar types of dedicated supported services. So providing, and Dennis, you can speak more to this than I can, providing emergency housing services, linkages to permanent kind of sustained housing moving forward, along with the case management, is essential to stabilizing folks after this period of trauma.
Definitely, and I think sort of to your point, Shamsher, right, sort of a lot of the work has been framing it, saying this is a vulnerable population, because, many, unfortunately, of the individuals who have been victims of trauma are not viewed sympathetically by the system. They're not as cute as babies and puppies. So they don't end up getting the resources devoted to them. And I think really pointing this out and saying, look, this is a structural problem, we need to address this, and get the resources in to address that. And I think, sort of one other thing on this area is bringing in additional partners, not just those direct service providers, but also bringing in sort of additional advocates to help. And for us, I think, our medical legal partnership has been huge in terms of bringing in lawyers and putting them into the healthcare setting. And the expertise they bring, right, they can help someone with their evictions, or someone, unfortunately, who is now experiencing disability as a result of their trauma. They can help them get over the hurdle with an SSI application to really help stabilize them. They can help with benefit denials, a lot of different things. And I think, especially in a population that has so many complex challenges as a result of their trauma or leading to their trauma, sort of bring in allies is really helpful in terms of really being able to make those existing resources go as far as possible for patients. And then in terms of sort of moving beyond sort of the granular, what we think are different components, key components, to provide holistic treatment to individual patients, we now wanted to sort of shift the last part of the discussion towards a little bit about what are some of the systems changes that Shamsher alluded to with that public health framing. So I'm going to turn it back over to Shamsher to talk about sort of some of the systems framing and conversations that we need to do to address these underlying structural issues.
Yeah, thanks, Dennis. And, so if we kind of go back to the beginning of the presentation, Dennis has hit on a lot of the things that address, the vulnerabilities at the individual level. But if you remember, as, part of the history of how we got here was kind of institutional problems and institutional racism. And part of that is kind of the intertwined nature of our healthcare system with law enforcement. And apologies if folks kind of listened into one of the didactics earlier, where I shared a couple of these slides, but this basically shows, how different communities, particularly communities of color, have distrust of law enforcement, and how that distrust of law enforcement is correlated with distrust of the healthcare system, oftentimes because they kind of cohabitate and co-locate, particularly in poor communities of color. So we have to recognize that. We go to the next slide. And this is just kind of the body of evidence that just bears out that the healthcare system is, oftentimes mistrusted because there is this concern of law enforcement presence or being turned over to law enforcement. So, interviews with victims of violence, patients who are undocumented, patients who are homeless, all say that one of the barriers to coming to the hospital was fear that they were going to get turned into police or ICE or whatever law enforcement agency there may be. So recognizing that this is a barrier to creating a system of trauma care where the patients feel like they're going to be made healthy and whole is important, and efforts need to be made to kind of extricate these relationships. And what we found here in California, and it's similar in other places, is that victims of crime compensation, which is funding that's available to people who have been victims of crime, such as temporary kind of supportive housing, mental health services, are oftentimes contingent upon people giving their reports or participating or being basically complying with the law enforcement investigation. So if someone says that they're not going to speak with law enforcement about whatever happened, suddenly they're no longer eligible for this body of funds, which is kind of like billions of dollars nationally. So how do we get to this point where suddenly getting some of these essential trauma recovery services is contingent upon complying with law enforcement? Hopefully some of those earlier slides helped answer the question in part, but we have to work to unravel this relationship for patients to feel welcome in our healthcare systems. Go on to the next slide. And this, kind of continues from our institutions to more of the structural interventions, and totally applaud all the work that's being done around gun control legislation and advocacy as a key driver of violence. But, there's much more, that doesn't necessarily address some of the other structural issues that we've spoken to here. If we remember the slides that I mentioned earlier, we have to undo that trajectory where all of the money kind of went out of our supported services and into our jails and policing system. So we got to take that money out of those systems and put it into the mental health services that don't exist, the substance use programs that don't exist, and also the violence intervention programs that don't exist. To give an example, and I know people are doing amazing work in other parts of the country, LA County passed a ballot measure after decades of organizing called Measure J, which secured 10% of our county budget, so about $500 to $900 million every year to go to community-based systems of care, with a strict caveat that none of the funds could go to law enforcement efforts. So a very concrete effort or win in terms of reversing, some of the structural trends that we've been talking about the last 30 or 40 years. And then the second part of that is not necessarily we're going to take all the money from one bucket and drop it into our healthcare system, because hopefully, as we've shown here, there's a lot of problems in the way our healthcare system has worked with, communities that have been made vulnerable. So we have to create new systems of care, and healthcare workers and particularly emergency medicine providers should be on the front lines, not on the front lines, but they should definitely be a part of those conversations. Individuals from the community should definitely be in the front lines, but we have to recognize that reimagining what community systems of care and safety look like is a very active and ongoing process that we need to participate in. And lastly, we have to recognize how the trauma system was built, where we're going to pluck people out of their communities and bring them to our trauma centers and, make them well enough and discharge them. And we have to reverse it. And the only way we can do that is to lend community increased control over the way our systems function and the way our institutions operate. So we have to be very intentional in doing those things. We can go to the next slide, Dennis.
Definitely. And so, I think, the hard question always comes, right? Okay, that all sounds great, but how do I pay for this, right? And I gave you a conceptual framework earlier in saying that, yes, you can pay for it because there's money in the system. But the hard part about this is it's not like every dollar is not spoken for, right? It's not like there's health systems are saying we've got millions of dollars in excess that we just don't know where to blow it, right? It's going to pay for something. So I think, part of the framework we presented was the interventions you could put in place, and preventing re-injury is going to save someone some money. It's not necessarily going to save a trauma center money, right? Because they're going to have one less trauma case, one less activation, which is actually quite a lot of money for them. But it is going to save the insurance company and if someone's uninsured, maybe the hospital, right? But often probably the government some money. So there is that money that exists, right? But the question is, how do you get that money? Like, obviously in academics, we're most familiar with applying for grants. And you can apply for grants from like research groups, NIH, CDC, and some of that money is starting to come back under this administration. But there's also sort of, foundation grants. But I think our point really is not to say, oh, here are some grants from the CDC you all should apply for, or here's some foundations you should look at. It's really thinking about this as a complex problem, as illustrated, right? There's a lot of components, a lot of things to address, which means the funding may also be complicated. And there's this term that I think isn't really taught in med school or in residency that I find really important. It's called braided funding. And what does that mean? It's basically thinking about you have a lot of different streams of funding, right? Maybe not any one stream is enough to pay for something. But if you do braided funding, you sort of pull, you say, okay, well, 20% of my my patients who are victims of trauma are experiencing homelessness. Let me go look for some money in the homeless service sector, right? What am I doing that ties into their goals? That'll get me some funding. Another 15% are food insecure. Let me go look into the food world and see what I can get. 100% have issues related to mental health, either prior or after. Let me go look in the mental health space and see what funding's available. And you sort of piece it together. You braid together all these streams of funding and sort of put together a program, even if there's not sort of the impetus in your local community or at your local healthcare institution to fund this outright, right? You can sort of put it together into a cohesive program that addresses all of these issues and also is sustainable from a funding perspective. Shamshir, do you have any thoughts?
No, I think it's a great point. And I think it's, it's oftentimes overlooked, but it's just recognizing that there's many elements of the vulnerability that exist. And we have to be able to address all of them. And it's not always an easy answer. The other thing I'll add on funding is that there is, some movement kind of at the federal level to potentially introduce a lot more funds. So this next slide. So basically, there's going to be increasing loans and potential opportunities to use Medicaid to fund for some of these programs. So I encourage folks who are in different places to seek out some of these resources. And the HAVI, which is health, I can put the link in the chat here, but it's a great group that's been sharing information with hospital-based violence intervention groups around the country about how to access these funds. So if you're interested in starting one of these programs or kind of augmenting it, take a look at those resources and, in addition to everything else that we mentioned.
Yeah, and I think in addition to Medicaid, potentially reimbursing directly for these programs, I think the other key is, every state does their Medicaid waiver, right? There's sort of two rounds of waivers. There's a 1115 and a 1915B waiver. Two technical terms if you work in the Medicaid space you're well familiar with. But the bottom line there is, why I bring those up, is those allow for flexibility, right? Different places around the country are doing different things. Some places are paying for lawyers. Some places are paying for housing. Some places are paying for food. There's no reason why this work also can't fit in under, sort of a in lieu of services framework. And what that means is basically, if I provide this, it's going to cost Medicaid less than if I were to provide traditional care. And I think we all recognize that trauma is expensive. And so if you're able to show that these programs are effective, and there's, I think, enough literature out there to argue that, one could argue that you're going to save the Medicaid system a ton of money by implementing these programs, and getting that sort of put into your state waiver is another way to go. But, sort of for me, I think it's sort of going back to that braided funding stream. It's very much thinking about, you think locally, think at the state level. I think often when, we think policy, we think DC, that seems intimidating. But there's sort of that counter phrase that all politics are local. And, you can sort of go do a lot of stuff, as Shamshir mentioned, Measure J in LA County, right? A lot of stuff happens at a local level. A lot of funding is local. And, as a ER provider, you do have a platform. There are people who are interested in hearing from you, and your word and your advocacy carries a lot of weight. So, whether this be at a cocktail party, whether this be at a white coat ceremony, this is a graduation, if you're doing this work and are interested in it, have your pitch ready, right? Have that soundbite ready. You never know who you're going to run into, and some of the best collaborations come out of the most accidental circumstance. So I would say, definitely keep that in mind as you move forward. And then Shamsher, turn it back over to you.
Yeah, I think we'll wrap up with that. We just got a few minutes. I don't know if folks had questions.
Yeah. So happy to take any questions. Thank you, Ruby. I like the link in the chat. But if not, this is our contact info. Definitely feel free to reach out. We're happy to chat at any point, and sort of think through things, brainstorm, figure out how to get into some good trouble together.
I have a question. So I'm Patty. I'm a med student, so I admit to not having a lot of knowledge in this area particularly. But from what I understand, a lot of the violence recovery programs at hospitals across the country are like pretty non-standardized in what they do. And I was wondering if you guys know of any that kind of do particularly well in kind of preventing re-injury, and if there's like any research on that, and if there's like any kind of view looking forward of these becoming more standardized in a way that like we know is more kind of works well, or do you think that because of like differences in communities and differences in resources, they kind of have to be a little bit different depending on where you go?
I think it's a great question, and the hobby that the website, I think they have at some place like the evidence base where different places that have done evaluations of their programs and shown decreases in re-injury. And increasingly what we found in this world of work is that re-injury it's an important endpoint, but it's probably not the most important. A lot of the things that we're hoping to attain is changes in the quality of life, people's perceptions of safety, all these other things that aren't captured in the historic metrics. But you raised still a great point. There is a lot of variability in these programs, and I think you got both of the answers, where the programs have to be different based on the local community and the circumstances. But I think, and Dennis, be interested in your thoughts, there's definitely some things that we're learning in terms of processes and ways to potentially structure things that can be shared across institutions. And I think, fortunately, more of these conversations are happening. I think one of the complicating factors is that, the relationships between community organizations and hospitals and health systems, it's things that take time to work through. But hopefully more and more, as this becomes like a routinized part of, expected trauma care and management, that we can kind of bring all the boats up together.
Definitely, and I think I agree with you, right? I think, in my mind, everybody likes to think they're special, which is not necessarily a bad thing, but it's a sort of very American in some ways. But I think, quite honestly, as much as different as communities are, right? Like, no one says, oh, there's a little bit of difference, but no one says now, oh, we're not doing a cath because we're a special community, right? So I think you do, sure, what does your cath team look like? Potentially may have some variation, or sort of where you send your cath patients and where they follow up has some variation. But there is some standard of care, and I think this is the same thing here, right? Yes, you obviously have to account for local differences, right? Not everybody has Measure J, or not everybody has, this particular nonprofit in their community. But there's something that looks like it, right? And if there's not, someone needs to start one. Right? So, but I think it's sort of, the components are the same, even the players are different, right? So that's sort of how I look at it. And yes, you have to account for, maybe there's a different way you have to talk about this given the cultural differences in your local community, but the core components are still the same. So I would say, yes, you need to be culturally and community-based sensitive, but the core building blocks of the intervention are the same. Awesome. I think we're actually overtime now, so I think that brings us to the end. Definitely, if we can be helpful, please get in touch, and look forward to working with all of you over the next few years.
Yeah, thanks everybody.
Thank you.
All right, take care.